I want to thank you for joining us. I'm Mari Silbey, and this is a special US Ignite Forum event focused on the rapid development and successful deployment of Cornell University's COVID testing program. As you all know, US Ignite works with communities on solving problems through innovation, advanced networking technologies, and data-driven strategies. But with the pandemic upending priorities over the past year, we've had to do some adapting to address the crisis in front of us. Certainly, broadband and wireless connectivity is more important than ever, but I certainly would not have guessed last March, for example, that my colleague Scott Turnbull would soon be hosting an online discussion about 3D printing personal protective equipment, PPE, or that in our automated vehicle pilot program at Fort Carson, for example, that we'd be talking about protective health measures for passengers like plastic screens and face masks. In that same vein, our event today is specific to the circumstances of the current pandemic. We are here to learn from and connect with experts from Cornell who put in place a massive COVID testing program in a few short months. This is important given that many communities are overwhelmed by the virus and that the ability to test and isolate positive cases is critical for public health. But I hope it also offers valuable lessons for what communities will face in the future, whether that's the challenge of vaccine distribution or the delivery of some other service to large and/or hard to reach populations. Solving community problems requires knowing how to mobilize resources, manage data, and form creative partnerships. We're going to hear about all of these things today, and for that reason, I think this is the perfect way for US Ignite to kick off 2021 with our community partners. Regarding the format for today, we're going to start with a presentation from our guests, Dr. Diel and Kim Potter, Operations Manager for the Cornell COVID testing program. After the presentation, I'll come back on camera to lead a discussion with our speakers. And during that time, I'll also ask you to submit your questions through the Q&A window. We'll get to as many of those questions as we can with the help of my colleague, Scott, who will be collecting them throughout today's session. And that is it. I believe that is everything you need to know. Again, thank you for joining us today. And now I'd like to introduce and welcome Dr. Diel and Kim Potter from Cornell University. The floor is yours.
Super. I just want to give a little bit of a background of how we got here. My background, I came up through a manufacturing background. I worked in information technology for a while. I was in state government for a while, and then I drifted into academia. And for the past 20 years, I've been in veterinary diagnostics, both at Michigan State University and here in Cornell. And I took my previous experience about streamlining processes and using technology to help us in those processes to help me with this particular project. I have been on a mission to improve public veterinary diagnostic lab processes for the past 20 years. It's a difficult road because there is an immense amount of variability in veterinary diagnostics. So one of the really exciting things about this particular project is that we were dealing with one specimen and one specimen container. And if you think about veterinary diagnostics as a whole, we're receiving things in mayonnaise jars and plastic bags and whatever the veterinarian can find at the time to collect a sample. And so this was a real treat for us. And that came up multiple times as we were moving forward. So let me just get started then and talk about this particular program. Obviously, as a part of Cornell, there was a lot of preparation before we were even asked to do this in terms of how Cornell planned on approaching this and what would drive the decision-making for the university. So there were a number of individuals working on various forecasting models to predict, based on the level of prevalence, what we could expect in terms of infection rates if we did bring students back. And part of that was mitigated by more frequent testing. So the surveillance program was supposed to be frequently testing the higher risk populations so that we could capture infection quicker. So we were given this challenge to try and implement in a very short period of time. There was a lot of community concern about bringing the students back based on behavioral stereotypes that the students wouldn't respond in the way that we needed them to in terms of compliance with testing or in terms of behaviors. So there was a lot of public forums trying to address those different issues. The compliance issue really drove a lot of how we developed this program. So at the time that this was being considered, the nasopharyngeal swab, the one that goes clear up into your brain, that was the gold standard for testing. And we recognized early on that if you do that to a student once, it's probably the last time you'll be doing that to a student, unless they're really symptomatic and not feeling well. So Diego's team had to do a significant amount of testing to try and assure the university that if we used a different type of swab or a different collection process, that we could get the same type of result in that testing. And so that was a big part of what they did early on while we were trying to figure out how to roll this out. And as a result, we ended up going with the anterior nares self-observed type of swab, or self-swabbing observed. That was the other key. There was a lot of conversation about doing saliva collection and having it be unobserved. And again, there was a concern about compliance and an individual's ability to drool effectively into a tube, and maybe finding the person on the dorm floor that was the best drooler and using that for all of the tubes as opposed to submitting individually. So there was a lot of conversation around that before we could get started. And once we settled in on that, then, and that took a lot of time, and the window kept getting shorter and shorter trying to make these decisions. So the beauty was that Diego and his team already knew how to do high volume testing. The challenge was trying to figure out the robotics for the sample pooling that needed to be done in order to make that happen. And I was somewhat concerned about the robotics because I'd had a lot of experience in that over the course of my time with veterinary diagnostics. There are multiple different robotic instruments that are available. And fortunately, they settled on one that had expertise in Cornell already, which really made a big difference. It made the programming a lot easier. They had a very focused effort once the machinery arrived to make that happen. So that was one of the things that moved things forward quickly. Even though we knew how to do high volume, the robotics can sometimes be a challenge to make it interface with various systems.
So just to be clear, that was a partner that you had worked with previously, and so they knew the systems, and that was a thing that helped to smooth and streamline the process?
Exactly. It was someone else down campus that had worked with this particular robotic unit before in relationship to PCR testing. So that experience already existed at the university, and we partnered with that individual. And that came up in the initial conversations when we were looking for how we were going to do this. There was PCR expertise beyond what's here in the veterinary diagnostic lab, obviously on campus. And there were a lot of different conversations, and probably Diego will talk a little bit about them, about different pooling strategies and algorithms to make this work. And we went with a pretty straightforward approach that we've used. We actually use it here in pooling milk samples for mastitis testing. We use the same approach that we used for that. And I think that really helped us move forward quickly. Anything more complicated than that would have just delayed making this happen in a timely manner. So in terms of other partnerships, the local hospital, so that's our Cuga Health System, they came in, and also Cornell Health, which is our student health organization. And both units came and looked at the space that we were talking about, possibly using for the laboratory. It was actually a research space that was supposed to be redesigned for a larger research laboratory. It was unused because of the shutdown, so we repurposed it for COVID. It's still a pretty tight fit, and we've got a lot of stuff going on in there, but it's working really well so far. We have a really strong team here, and I think that was so critical in the success of this, bringing in the people that were decisive, that could make decisions and make things happen. And that went from everywhere from facilities to our veterinary IT staff, which was very skilled at all of the interfacing that needed to happen between the robot and our veterinary information systems, which is a program that we use for all of our veterinary diagnostics. It was something we were familiar with, so we didn't have to build anything new. We took what we already knew and we just modified it to fit for COVID. Then the Cuga Health came in and kind of helped us with the human side of that, because we've never done human testing, right? And everybody was worried about HIPAA and how we were going to make that work. And the way that the systems ended up being integrated, the laboratory system that runs the tests does not have any HIPAA data in it. It's all de-identified data. There is a single identifier that links that result back to a registration system that is managed by Cayuga Health. They already had that system in place. They were using it for COVID testing before. So we were able to take that identifier from that registration system and use it in our testing process, but then send the result back to that same ID, which then links it to a result in their medical record system. So there's actually 3 systems involved here. The laboratory system with de-identified data, the registration system, which gives us the opportunity to make reservations and distribute the flow of people coming in to get tested, that was managed by Cuga Health, and then the system, the medical record system that exists with Cuga Health that has all the HIPAA protected data and all of the results. So we leveraged those 3 things. We didn't have to build anything new. We had to do some modifications. And I think also Diego will talk a little bit about that, some of the applications that our IT staff was able to pull together in our veterinary diagnostic system to make this all work. So we can go to the next slide. So just some of the numbers, and this is all from this past fall. We were collecting on the order of 6,000 to 7,000 samples per day. This was a 7-day-a-week operation, which initially I naively thought we could do it 5 days a week and do 4,000 tests and everything was going to be okay. And then they came back to us and they said, no, well, we want to test the undergraduates twice a week. So you're going to have to do more per day. And oh, we want you to test 7 days a week because we don't want them to be free on the weekends to do unacceptable behaviors. So this ramped up really quick, and every meeting, everybody's eyes just got bigger and bigger, but we managed to pull that off. So as a reference, we've completed almost 550,000 tests between last September 1st and now. And the Animal Health Diagnostic Lab, which is our base veterinary diagnostic lab here, processes on the order of 700,000 different samples in a single year. So we will be exceeding the number of samples that our diagnostic lab processes in a given year. But again, it's one single sample type, all in the same container. And the fact that those 2 things exist are what has made it possible for us to do this much testing as quickly as we have. That comes to about 4% of the total testing for the state of New York. We have a very large collection site staff because we have sites open 7 days a week from 7 in the morning until 6 at night. There are 7 sites on campus and 3 sites off campus, because a large portion of the student population lives off campus, and that was really one of the riskier populations. So we wanted to make it as easy as possible for people to get tested. And the collection sites were all sort of based on the format that Cuga Health Systems already had in place for collecting samples. So we had to do a lot of changes. The picture that showed here, we were using plastic shower curtains as a protector between the people that were collecting and the people we were collecting from, until the fire marshal told us that plastic shower curtains were flammable and we couldn't do that. And then we had to go to plexiglass. And these are changes that happened like within 48 hours. We had to flip the entire thing. We were just throwing this together with rubber bands and duct tape at the very beginning. But it all managed to work out really well. The laboratory now has 16 full-time people and 10 to 12 part-time. The reason the staffing has increased a little bit this spring because we're expecting to do significantly more student testing and also more community testing. So in a previous conversation, Mary mentioned that Syracuse was one of the cities that was part of US Ignite. We're actually doing testing for Onondaga County because their prevalence rate is so high. So we have capacity now to handle not just the Cornell population, but surrounding communities. And those decisions are being made strategically between the university and Cuga Health to benefit those groups as much as possible. So I'm done blathering. I'll let Diego take over.
Thanks, Kim. Thanks, Mary, for the invitation. It's a pleasure to talk a little bit about what we have been doing to actually what we have done and what to get this lab and the program up and going. So my background, I'm a veterinary virologist, and I have been doing research on virus host interactions, vaccine development, and diagnostic assay development for several years now. As part of my appointment at Cornell, I'm also the director of the virology lab at the Animal Health Diagnostic Center. And that's how I got involved in the COVID testing program. So the initial challenge that was posed to us by the university was actually to develop and validate an assay that could be used on this testing program, and also to validate, as Kim mentioned earlier, a specimen type that would be more amenable for frequent sample collection than the nasopharyngeal swab, which is now is still considered the standard sample type for SARS-CoV-2 diagnostics. So in the summer, we started basically the whole project trying to validate the assay that we were going to use or that we were intending to use, and then validate an alternative specimen type to be used during the fall semester. So we partnered with Cayuga Medical Center and Weill Cornell Medicine New York City to validate the assay and those alternative specimen types. We started the whole project by comparing the three main specimen types: a nasopharyngeal swab, which is the standard, the nasal swab, which we ended up selecting and are currently using, and saliva. So we compared the sensitivity of these three assays and realized that nasopharyngeal swab and saliva are the specimens that have a little bit of a higher sensitivity. However, the nasal swab, even though it presents a lower sensitivity, we were still able to use it based on model predictions that was performed by another colleague here at Cornell, that by increasing the frequency of the sampling and the testing, we would probably be okay by using nasal swab as our specimen type. The main reasons for selecting that was basically concerns with compliance, as Kim mentioned earlier. We knew that students wouldn't probably show up for a second collection the same week if we were going to be doing the nasopharyngeal swab. So the nasal swab was selected, and that basically started the whole testing program.
So that's really interesting that the factor was not just the performance of the type of specimen collection, but that you considered behavioral compliance as part of that and also ran modeling to determine what would be acceptable given the potentially lower sensitivity rate of the nasal swab based test. I'm just reiterating that because I think that's probably a consideration many people had not thought of in terms of how you go about testing. It's not just about which test is going to be, most effective per testing instance, but what's going to be most effective given community behavior as well.
Yes, that's correct. And Peter Fraser did all the modeling to establish this testing program here, and he took into consideration the different sensitivity of the specimen types to come up with the testing frequency for each of the populations at Cornell. So in this slide, basically what I'm showing here is the workflow in the lab. So everything starts with sample collection, as Kim showed in her slide. Then once the samples actually arrive in the lab, and actually let me step back a little bit. I forgot to mention that in addition to validating the assay, the specimen type, we also needed to validate a pooling strategy so that we're going to be able to accomplish this massive testing that was actually being requested from us. So we also did comparison of different pool sizes to determine which was the ideal number of samples that we could pool without actually losing sensitivity of the assay or significantly compromising the sensitivity of the assay. And when we ended up validating pools of 5 samples, so that's what we decided to go based on the performance of our assay in pools of 5 samples.
So for those who might not know, can you describe what that pooling means? I mean, it sounds like it's pretty self-explanatory. You're taking 5 tests or 5 specimens, pooling them together and seeing if there's a positive result from that group of 5. Is that right?
Yes, that's correct. So there's basically 2 different ways that you can do pool testing. One would be you would collect individual swabs from 5 people and you would place them all in one tube. In the tube that is showing here in the left. So that would be one way of doing pool testing. What we ended up doing is we collect individual swabs, we place them in individual tubes, and then once the samples arrive in the lab, we will mix them. So we mix a constant volume of each of those swabs into a single well of a 96 well plate. So we'll take, for example, 200 microliters of the viral transport media that is present in that tube, and then we will mix 200 microliters of 5 different samples into one well and then perform one single test in those 5 samples. So we're basically testing 5 people with one test. And the whole idea of using pool testing is that you increase the efficiency because you're actually testing 5 samples in one with one test. You reduce the cost significantly of the testing program. And if you select the correct pool size, then you're also not affecting, the sensitivity of the assay per se. So what we do when the samples arrive, the individual tubes from the collection sites arrive in the lab, we'll transfer them to our liquid handlers. And then those samples will be pooled using the liquid handlers or the robotics into a 96 well plate, which is shown in the bottom of this slide here. So 5 samples will be mixed into one well of this 96 well plate. And then once we have 93 pools into that 96 well plate, the plate will be transferred then to the next step of the process, which is basically nucleic acid extraction, where we're basically purifying the viral RNA so that we can actually detect it with the real-time PCR assay. So once the RNA is processed, that the pooling step is a step that takes about 45 minutes. So in 45 minutes, the robot can actually take 455 samples, individual samples, and pool them into 93 wells of a 96 well plate. Once that's done, the 96 well plate will then be transferred to the nucleic acid extraction station, where we will actually do extraction of those 93 samples simultaneously. That's a step that takes about 30 minutes. Once the nucleic acid has been purified, we'll transfer that to the detection instrument, which will actually perform the real-time PCR reaction, and that takes about an hour and 30 minutes. In this step, we actually use virus-specific reagents, primers and probes, that will ensure that we're actually detecting only SARS-CoV-2 RNA in those samples. Once that process of detection and amplification is done, then we'll proceed to data analysis and reporting of the data. So the real-time reaction takes about an hour and a half, and then analysis and reporting another 15 minutes. So we're basically talking about 2 hours, 3 hours to 3 hours and a half from the time that the sample arrives in the lab until we can actually report results out to CMC, which is our partner that handles all the individual sample results. So as I mentioned earlier, what we do is tests. We run the test in pools of 5 samples. So at the end of the first round of testing, we have, if we detect a positive well into that 96 well plate, we don't know which of the 5 samples that made up that pool is actually the positive patient or the positive person in that pool. So the next step of the process is the deconvolution of the pool. So we will go back to the individual samples that made up that pool and retest them individually so that we can pinpoint exactly which of the 5 patients that made up that pool is actually the positive within that pool. So we go back to the individual pools. We will run the nucleic acid extraction again, and then those samples will be tested individually using the real-time PCR. And only then we actually report the results to CMC and Tompkins County Health Department so that they have the ability to contact that person and put them in isolation or quarantine. So this is just a slide showing the data workflow, and Kim mentioned a little bit about this, and this is perhaps one of the most important aspects of this operation, and was critical for the success and for our ability to actually test the volume of samples that we did in the spring semester. So the whole process starts with registration, sample collection and registration of the patients at the collection sites. And that's all managed by our partners, Cayuga Medical Center, which is a local hospital in town. So they manage that registration process, and they retain all the patient identifiable information in that system. Once the sample arrives in the lab, we will perform accessioning of those individual samples. So the only information that we record in the lab is basically a barcode number that is attached to each of the tubes that are collected in the collection sites. Through that process, so that accessioning process is actually performed by barcode scanners that are present in the liquid handlers that will perform the pooling of the samples. So as we load those samples in the liquid handlers, the barcode readers will actually capture the barcode number on each of the individual tubes. And at the end of that process, we'll have a report that is generated by the software that drives the liquid handler. And that software will capture not only the identity of the tube, but it will also capture the location on which that particular sample is added into the 96-well plate. So that location in the plate, pool plate, is captured by the liquid handler. And that's it also captures the storage location of the individual samples, so that once we need to deconvolute those pools, we can go back to that report and find individual samples that made up a positive pool, for example. So the whole system here was, and the integration of this data was managed by our IT group that actually works in the Animal Health Diagnostics Center. And the new addition to the system that we use regularly at the HDC is the software that generates the report from the liquid handler that's called DART. Then the DART software actually transfer the data to other apps that we regularly use in the Animal Health Diagnostics Center, our receiving app and the PCR app. And those two applications are also linked to our LIMS system, VetView, which is basically the same laboratory management system that we use for animal testing at the HDC. So this central portion of this picture here, we're only handling with the single barcode number that Kim mentioned earlier. So there's no patient identifiable information that's being managed at this time. Once we have the results ready to be reported, the system, again, our VetView system is integrated to the CMC system, which is the Cayuga Medical system, and results from individual samples will be linked to the identifiable information that is retained in the CMC system, and they will then transfer the results to the Tompkins County Health Department or Cornell Health. When a positive patient is actually a student, Cornell Health will conduct the contact tracing and isolation procedures. When we're dealing with a staff or a faculty member, the Tompkins County Health Department will do all the process of contact tracing and follow up with any of the positive cases that we have. Basically, I think that's what I had to present. And now I would be happy to answer any questions.
That's great. I appreciate it. I'm going to take us off of screen sharing here. And what we're going to do now is I'm going to ask some questions and sort of get this conversation going. And then I know we have some questions coming in through the Q&A window. I'm going to encourage everybody who is attending to please submit questions through the Q&A window. And as we move forward, my colleague Scott will introduce Scott and have him come on and give us some of those questions as we move forward. But I'm going to start the discussion because the work that you've done is so impressive, and it shows that it is possible to administer massive testing, despite the fact that we haven't done it successfully across much of the U.S. Obviously lab capacity is critical, but it's more than that. What do you think has stopped us from being able to replicate the success that you've had, that type of success, in other places? And what could and should communities be doing to facilitate better testing?
I think one of the really key factors was the combination of people that were engaged in this. There wasn't anybody on the team that was interested in, I don't know how I want to say this in a nice way. everybody was really focused on what the objective was, which was to create a testing entity that could not only handle Cornell University testing needs, but also relieve the local hospital from having to be responsible for Cornell's testing needs. And knowing that, okay, we're going to take this burden off you, but this is also going to offer opportunity for you as a hospital to do even more testing than you would be capable of doing without Cornell. It was a really good relationship, and the people, you know, there's a lot of different reasons that people enter into partnerships. I think that at the very beginning of this, I'd like to say this because I'm not paying the bills, it was never about the money. It was about what was right for the community. And you can say that the university went into this because obviously having students here is a revenue generating enterprise, but at the same time, Cornell's really focused on wanting to teach these students and do the research, and they're totally committed to that. And I think what surprised us all, we thought the students were going to be the riskiest population in this. When the students got here, there were very small pockets of misbehaving, but for the most part, the students wanted to be here so bad that they would do just about anything to make that happen. And so when we talk about compliance, you know, everything's on a bell curve. You have people that always want to buck the system, or I think we had maybe 8 students through the entire fall semester that made every testing appointment that they were supposed to out of 22,000.
Wow.
But we had really wonderful compliance because the students wanted to be here. They wanted to be here studying, and they wanted to, you know, they wanted to be here with their friends, even if it was only from a distance. So I think everybody was focused on the benefits of this, and some of the other discussions that can sometimes derail things just did not misdirect us or take us off course. So, but it was also, you know, a function of having the right people in the room the entire time. I don't think there were any naysayers. Everybody was pretty pointed forward from the get-go on this.
I assume there was some partnership or relationship in place with Cayuga Health with Cornell and Cayuga Health prior to the pandemic.
Right. So they already had a working relationship with our student health program.
Okay.
We did need to jump through obviously some licensure hoops, and the lawyers on all sides were involved, but we managed to kind of keep them in the background. And to be honest, we didn't finally settle the financial piece of this in terms of crossing all the T's and dotting the I's until December. So, you know, we didn't let that stop the program from moving forward. We figured we'd get it all straightened out in the end, that we needed to just keep moving. And so I got to give the entire team credit for that. And this is really at the higher university levels for staying focused on what we really needed to do from a community perspective and from a student perspective.
So that brought up a point, the funding certainly, or the cost measures, but also you had to, whether it was software licenses or whether it was procuring the equipment, you had to, again, sort of do all of this, and it was brand new and you had to do it very quickly. Were there any particular strategies that you used to streamline the procurement of equipment and supplies, and also to ramp up staffing, since that was clearly a huge issue?
Well, the equipment was a bit of a concern. We're even in that scenario right now. We're waiting for another robot to come this week to help us fill tubes with media. We need to double our capacity to do that. And again, that was a decision that we made early on, that we weren't going to buy pre-filled tubes with media because that was a riskier endeavor than having the flexibility to buy our own tubes and fill those with media. So there were challenges with equipment. I believe the first Biomech robot came the week before we were supposed to start testing. Maybe it was 2 weeks. Do we have 2 weeks? Maybe a week and a half? Yeah, there was quite a bit of scrambling to get that thing up and running and to prove, I mean, we hadn't even proved that we could do this yet. In the fall, we were concerned about getting 300 samples. Now that just makes me laugh considering how much we can process. But yes, the equipment was a challenge. I would say probably from a supply chain perspective, and we had somebody specifically that was their only job, was to make certain that the supplies were going to be here and that we would have adequate quantities. The biggest challenge was the plastics. Because we needed to buy a lot, they weren't always available in the same format. And so I think we've dealt with maybe 4 different tube types, which that affects the robotics, it affects the collection process. A lot of different aspects of that that we've needed to be a little bit more flexible about to adapt. So that was probably, I think, our biggest challenge and our only really big worry, where we were down to maybe 2 weeks worth of plastics, and we didn't know when the next shipment was going to come in. And we're competing with everybody else. So I can't say we did anything really Herculean in that. We just had somebody that was very dedicated to it. We tried not to pull the Cornell University card if we could avoid it, because everybody needed supplies, right? We're not any more or less important than anybody else out there trying to get testing supplies. So I think we navigated that fairly levelly in hindsight.
I would just like to add a few things. I think that one thing that gave us sort of an advantage in terms of supply chain was that we engaged with the suppliers pretty early on, even when we weren't certain that the university was going to establish the program. We started having discussions with them and requested quotes for the semester. The other aspect of it is on the assay that we're currently using. We partnered with a small company that actually does and develop diagnostic assays for human tests and for animal health as well. So we partner with them to validate their assay so that they ensure to us that we would have the tests throughout our testing program.
Right. So early engagement and early validation and throughout that process. That's excellent.
But the other piece of that is that the veterinary diagnostic, so it was a space that maybe not everybody else was looking at when they were looking for supplies. So that was a little bit of an advantage to us also.
Interesting.
Because the major human testing organizations are all getting slammed by the hospitals or the other labs that are looking for this, whereas we're a little bit smaller, more of a niche thing. And I think that was really played into the success of this.
So is there a different pool of suppliers or were there different options because you were coming at it originally from being a vet lab as opposed to a human lab? Is that what you're saying? I think
there's a lot of public suppliers that are, human medicine's where the money is, right? Mm-hmm. They dabble in veterinary medicine where they find it lucrative. We find ourselves in a position quite frequently where they just decide, oh, this assay isn't worth producing anymore, and they stop producing it, and all of a sudden we have to drop a particular test or find some other workaround. So they're interested in partnering with us if they see a financial incentive in it, and I think in this case it worked out to both of our advantage.
Sure. Well, you're giving them quite a bit of volume, so that would certainly make sense. I have a number of other questions, but I want to invite Scott, my colleague Scott Turnbull, to turn on his camera. I know we have at least oh, you're very green, Scott. I want to invite Scott. There we go. I know we have a few questions coming in both through the Q&A and the chat window. Do you want to select some and bring those to the discussion, Scott?
Sure. I'll start with some that was sent through the Q&A button first. And this is for Diego. It's from FHSP. They're sending a question about the data workflow slide that you had. And they asked, is Cornell utilizing predictive analytics to explore variables which might indicate increased likelihood of positive? And they're also asking, does the single bar code connect back to demographic information, for example, race or sex?
The answer for the first question is no. I don't think we're using predictive analytics. I mean, we are using real-time data to monitor the situation. The university has an infectious control committee that meets twice a week to look at the data that is generated and coming out of this program. And they monitor the situation and then make decisions based on real-time data that is being generated from the lab. And what was the second part of the question again?
Sure. And the second was, does the single barcode connect back to demographic information, for example, race or age?
It does connect to the person's name and date of birth.
In the Cuga Health system, it would link back to that information, but it's not a part of the data that we receive. So that's one of the challenges that Diego is faced with right now, is he has this de-identified data that certainly he would like to be analyzing across to all that demographic information and getting the appropriate permissions and abilities to do that. That will probably take another, I don't know, 4 to 5 months, 6 months, hopefully not that long. But that's something that we have to be very sensitive to, right? That it's an important information, but the permission to use that data for that purpose has not been granted for these samples.
Great. We also have a question from David Broker that came in general text. They say, congratulations on your outstanding efforts. I'd like to echo many of the same comments from a Purdue perspective. Questions for the panel, there's 3 of them, so I'll start with the first. What are your plans to re-densify? I don't know what that means, I'm sorry.
Re-densify.
Yeah, we might want to, well, maybe we can get clarification through the chat.
Sure, if you have a follow-up, please drop it in the chat. I'll go to question 2. Are there any changes for the spring involving testing?
Actually, based on the infectious control committee that Diego mentioned, and the fact that the prevalence in the populations has changed. So initially we had higher prevalence in the student population, and then that went way down, and we started to see an increase in the employee prevalence. And that's because it's, heating up in the surrounding community, and employees are coming from around the Ithaca area into Cornell. And bringing that positivity to campus. So they're re-evaluating. In the beginning, the high risk was considered to be student facing. So, and of course, faculty was any of the faculty that were teaching in person were concerned about interaction with students. So the undergraduate population was tested twice a week. I don't think that's going to change, but there are some populations within the student population that are higher risk, which I won't target them, but you could maybe think about it in your head, that they may go to 3 times a week with that particular group, and also increase some of the employee populations, which we really didn't consider in the beginning would be high risk, but they're populations of individuals that tend to spend a lot of time working together in close quarters. A perfect example of that is our laboratory staff. We can't have them, working remotely. They have to be here at the lab working. And so we have a number of protocols in order to protect them from being here at the lab working. But should they be in a higher testing protocol group twice a week, 3 times a week, they're looking at all those different populations where we tended to see more positives in different employee cohorts, and saying we need to shift this. It shouldn't just be student facing, it should be employees that are interacting with each other at close quarters for longer periods of time.
And I had some clarity involving the redensifying was a local term they use at the university. But that question was, as they bring students back that went away for the holidays, what are your plans, retesting or anything you presented on related to bringing students back to the local environment?
So there's an arrival process that once a student states the day that they're planning on returning to campus, and this all has to be aligned with the current New York State travel protocols. So this again is an area where we have to be really flexible and able to move in order to make certain that we're meeting those guidelines. But right now the process is they tell us what day they're coming back. 2 days before they come back, they get an email that says you're going to get a link so you can sign up for your test. You have to get signed up for that test at 2 specific locations so that we're not intermingling them with all the people that are already in the surveillance program. They're supposed to self-quarantine for another 3 days and get a second test. And if both of those tests come back negative, and again, all that information gets fed back, or it gets fed from the lab to the Cayuga Health System and then back to Cornell as being compliant. If they have 2 negative tests, then they're granted privilege to come on campus and have access to campus services. So that system, that complete loop has already been operationalized and is ready for spring.
Great. And the third question is related to your plans for testing when the vaccine arrives in your local population. How do those plans get modified over time as the vaccine becomes more prevalent?
So again, the infection control group feels that the surveillance program should continue even after vaccination starts. It may change the frequency of how often we test, but until the infection control group feels that we have greater science to let us know if somebody that's vaccinated can or cannot be a carrier, they intend to continue the surveillance program.
Do you think that your team will have a role in vaccine distribution in the future? Is that something that has been considered by the university?
Was discussed this very morning. Because, you know, the collection process and the vaccine process are not dissimilar, right? You need an appointment, you need a staff that can do the pre-processing or herding of the individuals, and then you need people that are trained to give vaccination. Our collection staff can handle everything up to the vaccination part, and then we need to, you know, the hospital would have to help with the actual vaccination. And we've actually done that. In our collection sites in the fall, we partnered with local medical professionals to have flu clinics at the same time so they could get their flu shot and get their surveillance test done at the same time. So we're always looking for ways to leverage one staff or the other to help, and everybody's been very flexible. If the hospital doesn't have enough, we try to supplement. If we don't have enough, they back us up. So
it sounds like you'll be reusing some of the same organizational infrastructure.
Yep.
But can Cornell also be an actual provider of the vaccine? Is that under contemplation? How does that work?
So that's all driven again by the state of New York, and right now
Okay.
the state of New York is controlling it pretty tightly. The initial distribution of vaccine went through hubs throughout the state, and then to the local hospitals. So we got an allocation, or Cayuga Health got an allocation and did the initial vaccination, and that was based on recommendations from the Tompkins County Health Department, Cayuga Health Systems themselves, and they came to Cornell, obviously, and partnered with us. So our laboratory staff and our collection staff were all vaccinated. Now the rules have changed as of I think 7 o'clock this morning. And so we're trying to figure out exactly how it's going to be handled now. But Cornell itself has not been given vaccine for distribution. We've been asked for advice on how it should be rolled out because we're a large part of the community, and we have a really great relationship with our health department and the hospitals. So everybody's pretty much on the same page for that.
It's very interesting, and it is, I know that it is very much sort of state driven, and that it's also different in every state. So I'm in Maryland here, just outside of DC, and I know, at least in theory, what's supposed to happen next is the state is supposed to recruit healthcare providers or folks who could be distributors, and then sort of onboard them into the program and into the software systems that they're planning to use to make the further public distribution happen once you're past sort of that phase 1A or phase 1B. The other question I had is sort of around the community outreach piece, because, you know, the education, especially as you're expanding testing into additional communities, the education that has to go into it, whether you're talking about testing or whether you're talking about, you know, vaccination in the future, what are things that you think that local leaders could do to help providers make sure that the public as a whole has the information they need, that they are then participating in these programs that you are helping to deliver? Are there things that the communities, the local government, et cetera, can do from a public outreach standpoint that will support further testing and in the future vaccine delivery?
I think probably the biggest thing that helped us was to get a dashboard up on what Cornell's testing program was accomplishing. That really helped with the public piece. Of course, we're in a highly academic environment here, and so everybody's comparing the Tompkins County dashboard to the Cornell dashboard to and there's everything's about timing. So we spent a lot of time discussing the disparity between numbers, but after a while that settled down as they saw things were kind of tracking in the same general order of magnitude, general direction. So I think that transparency in numbers was really, really critical to our community and helped very early on. There were also some very targeted news stories in terms of how we addressed some of the early clusters, assuring people that those things were addressed rapidly and very effectively. That helped with the student population, understanding exactly how serious the university was about this, and in the public's understanding. So I would say as much transparency as you can in a medical health scenario, to let people know how things are going, and in as many places as possible. I just don't think we could have communicated enough over the course of this. And Cornell has a tendency to be very wordy in its communication because we are an academic university. We tried to get them to be a little bit more bulleted so that people would consume this, because quite a bit of this goes into just, trying to figure out how to say this in a succinct way and get that message across. So there are people that like to read a whole lot of stuff, and there are people that are looking for the Twitter highlights. So
Yes.
that was, you had to find a balance, I would say.
Yeah, agreed. Certainly, I know that a lot of our community partners are very much used to having to interface with academics and research folks as well. And there's definitely almost a translation effect that has to go on sometimes. I have one other question that's maybe a little bit out of left field, but I'm thinking, it's very nice when you talked about the fact that, really money was not, the bottom line in all of this was not a huge consideration because there were just higher priorities. Are there things that communities can help with, would think about doing, et cetera, that would be helpful as we move forward with more testing and vaccine distribution in terms of finding funding to support all of the infrastructure that goes into this? Again, whether that's equipment or whether that's staffing or whether that's outreach or whatever it is, are there ways in which new funding support would be helpful, that being able to partner with local governments who might have access to different resources might be useful?
This is a difficult thing. My real job is to watch the money on the HDC side and make certain that we're spending within our limits. And right now, this year, I know specifically we're very challenged because we get about 30% of our support from the state, and we have no guarantee that we're going to get that funding this year. There's probably going to be some really creative accounting at the end of all of this to make it work. So I'm not usually in a position to have to make those commitments without that funding. But I was thinking about it as we were going through this whole process, and we were hearing from different units across the United States about, you know, we have to do this and we have to do this and we don't have the funding. And yet we're still figuring out how to get it done because we're making different choices, right? We're making choices to just do it for the right reason and not wait for the money to come first. And in my mind, I think it's all going to figure itself out in the end. It'll all get reconciled, and all of the things that we did right because we didn't worry about the money up front will still be considered we've done the right thing. So it's maybe a little bit altruistic because I'm not paying the bills on this one. But I do have a fairly good idea of how much it's cost. I think in the end, we did the right thing, and we didn't let our concern for not being funded. There's money, there's always money to be found somewhere if it needs to be found.
Well, and certainly keeping students and staff and employees and faculty and everybody healthy also means that they can continue to be productive, which is ultimately what, you know, brings in revenue to the university as well. I am certainly, I think you're right about the needs for some, not just creative accounting, but creative, again, sort of partnerships to bring in the the supplemental funding that's going to be necessary, whether that's public sector or private sector. Pardon me, but finding those partnerships going forward. And I think it's going to be critical for providers such as yourself, and also folks who are going to come in on the vaccine distribution, to really highlight where some of the shortfalls may be, and to work with other local community partners to determine, you know, what resources they may have to help fill some of those gaps, or what are some of the best places to go to get some more funding when there are shortfalls, to make sure that the programs don't get delayed or cease, given the priority of getting all of these things done.
I mean, this is a public health
Right.
Catastrophe, really. We just need to make the right decisions and not be blinded or misguided in other voices.
Establishing the right partnerships is critical. Partnerships between different communities too. I don't think that every community will be able to establish, a testing program or vaccine distribution programs just because of lack of resources or expertise. But if, different communities can come together and try to come up with a solution that will help, 2 or 3 different communities, I think that's probably a good way of trying to establish something like this and expand testing capacity, availability of testing, and also, now hopefully vaccines pretty soon.
I'm so glad you said that, because, the mission really of our Smart Community group is to be able to share best practices, to be able to replicate successes in different communities. So I'm hopeful that there are some brainstorming and some discussions that come out of this, either people who potentially want to get in touch with you, potentially, to learn more and to be able to take some of those lessons and apply them back in their own community. And also just having further discussions in and among the communities here themselves. Hopefully this sparks some further cross-community discussion, because certainly there's no reason to reinvent the wheel. If it's working well somewhere, let's take that and make that happen in other communities as well. Are there any final thoughts that you would like to share with our group?
Wear a mask, wash your hands, social distance.
Very good.
Get vaccinated as soon as you can.
I'm ready to go, hang out at the pharmacy and wait for any extra doses they have. Yes, I want to thank you so much. And I will just say on a personal note, my husband is a Cornell professor, albeit based down here in Washington, D.C., which is how I knew about the program and also how I know how incredibly effective it has been. And I am thankful personally, and I am also so glad to have been aware of this so that we could bring this to more people as well. So once again, thank you, Diego, and thank you, Kim. We appreciate the time so very much. Keep doing what you're doing, and we are very thankful for it.
Super.
Thank you.
Great.
Thank you.
Thank you, everybody. This has been a US Ignite forum, and we look forward to talking to everybody again soon.